Good evening, everyone. So I'm Alex Kotlyar, one of the doctors at Genesis, and I'll be doing this webinar titled Fertility 101. So the first question is, what is normal fertility? So fertility, I'm sure as all of you know, is the capacity to produce a child. There's a related term called fecundity, which is a couple's ability to achieve a pregnancy every month. A few important numbers to know is that in a given cycle, a couple has a 20% chance of achieving a pregnancy. 80% of couples will achieve a pregnancy within the first 6 months of trying. Now, this ability to achieve a pregnancy is heavily dependent on a woman's age. So for a woman in her 40s, she's half as likely to achieve a pregnancy as easily as a woman in her 20s and 30s. This slide comes from a publication from ASRM, the American Society for Reproductive Medicine, on optimizing natural fertility. And it shows curves detailing the chance of pregnancy per month relative to a woman's age. And you'll see numerous curves here. These reflect various racial and ethnic groups that they studied. And all of them show a very consistent trend. Namely, that after the age of 35, the chance of pregnancy starts decreasing rapidly. Obvious question at this point, why does that happen, Dr. Kotlyar? The simplest reason is with time, eggs, they accumulate DNA damage. And that's due to a common culprit are free radicals. But over time, that accumulation of damage builds up in eggs because the eggs in a woman last for her whole life. And in contrast to virtually all other cell types in the body, eggs don't get turned over throughout a woman's life. So once they get some damage, the damage stays. So when I mentioned a concerted effort to try to get pregnant, I'm really talking about targeting attempts at getting pregnant during the fertile window. And the fertile window is basically the 6-day period that includes the day of ovulation, and that's when the eggs and the sperm are most capable of surviving, fertilizing, and then leading to a pregnancy. A bunch of studies have looked to address, well, is there any particular time in this fertile window, in these 6 days, that are most important to achieve pregnancy? And basically, the 1 to 2 days before ovulation, that's the key point. Then that begs the question, well, then how often do you time intercourse? Older thought would say that you can't do it too often, for example, too many times in the day, because that would deplete a man's sperm. That, to be frank, I'll just tell all of you, is rubbish. So it's as often as you two wish. It's as often as the couple wishes. So long as it's done ideally within the 1 to 2 days before ovulation, it can be done as often as the couple wishes. The limit, I mean, of course, life happens. We all have various obligations pulling us. It may not be possible to have intercourse every single day. So a good interval to have is to have intercourse every 2 to 3 days. Ideally, you're not spreading it out more than 5 days, because that can have a negative effect on the number of sperm available for each session of intercourse. This graph comes from that same publication where I showed the first one, showing the chance of pregnancy for a single act of intercourse, and that's plotted relative to menstrual cycle. So on the vertical bar, we see the percentages, And we see that the peak is at around like 9.4% ballpark. And we can tell that it happens like right around days 12 to 13, with ovulation happening around days 13 to 14. If one would have intercourse before then, so 12 to 13 minus 6, that brings us to about day 6 to day 7. And that's when the chance of fertility increases, but it's highest in the 1 to 2 days before ovulation. So then that begs the question, how does a woman reliably and consistently track her ovulation? There are a few methods. So there's the calendar method, and there are many apps that can help out with the calendar method. And one of the great things about these apps, so nowadays we hear about artificial intelligence and machine learning, all these buzzwords, buzz phrases. So there are apps that you can download on your iPhone, and even if they don't accurately predict ovulation that first month, by 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 putting more information month to month, they're going to get to know you in much more detail, and they'll be able to predict fairly accurately when your ovulation should happen. I think one fantastic app is it's called Clue. There are a bunch of very good ones, but at least in one recent study, Clue slightly outperformed many of the other apps. Then there's also measuring basal body temperature. This one also requires at least a month or two of self-tracking. So the way it's done is in the early morning, before you've even gotten out of bed, you measure your body temperature. Make sure you don't move, because any movement, any activity that generates heat, that'll raise your body temperature artificially. And you start measuring it on the first day of your period. And in the first half of your cycle, it'll be on the lower end, like in the 97% range. Then around days 13, 14, 15, you'll notice a jump. And that jump will be like about a degree. Likely will be even higher. Then that happens when progesterone is produced, and that happens after ovulation. So, say in 1 month, you can make this chart for yourself by measuring your body temperature right when you wake up, before you even get out of bed. And then you'll know that, well, if your chart looks like this one, then you're probably ovulating around day 14. So it's best to have intercourse on days, for example, 11, 12, 13, 14. Or if you're even busier, at least days 12 and 14. That way, there'll be plenty of sperm waiting for when your body releases that all-important egg. Other methods include cervical mucus monitoring, so the stringiness of the mucus. I won't go into too much detail, but after ovulation, the mucus can get even stringier. And to go figure, there's a German phrase to describe it. It's called Spinnbarkeit. So just very stringy, and very long lengths of mucus can come up with ovulation. But to be frank with you, the method that I think works the best, and I think this because I was a chemistry major in college, is because and for probably that reason, I like the urine ovulation kits, because that tells you when the ovulation hormone is being released. That hormone is called LH. It's reassuring for me because it's reality. It's the actual chemistry that's telling you your body is preparing for ovulation, instead of a chart or an app to predict when you're going to ovulate. Now, when you do these kits, you very simply dip it into your urine. You can do it once or twice a day. And when you get the positive result, most of these kits show a control band. And then when you have that surge in the ovulation hormone, then you're going to have a test band will get really dark. And that tells you in about 24 to 48 hours, so basically within the next 2 days, you're going to release an egg. So that's when you should definitely time intercourse. So there are many women who try all these methods. They're on point. They do everything possible to optimize their chance for fertility. Alas, alas, they spend quite a bit of time and it doesn't happen. So at what point should they really be concerned? So going back to what was mentioned. So 80% of women will get pregnant within 6 months. So in that situation, if a woman has reached that 6 month mark and nothing has happened, then then it's important to think about what could be causing the issues getting pregnant and what could be leading to infertility. So any risk factors for difficulties getting pregnant, subfertility, and infertility, they're basically four general categories. There could be structural issues, anything that could change the anatomy or make it just harder for an egg and a sperm to meet. They include endometriosis, especially if it's severe. That being said, there are many women with endometriosis who are getting pregnant. If a woman has a history of severe pelvic infections like chlamydia, that's also a risk factor. Anything leading to scar tissue like inflammatory bowel disease, like Crohn's, a history of very severe surgery inside the belly or the pelvis. Also, anything inside the uterus that can lead to scar tissue too, or lead to any anatomical changes. There could be endocrine issues, basically anything that makes it harder for a woman to release an egg each month. There could be ovarian issues. If there is an irregular cycle, common condition that's part of that leads to that is PCOS, polycystic ovarian syndrome. If you can't time ovulation accurately, it's hard to time intercourse. And so it'll be much harder to make sure the sperm can really meet the egg. Also, there are many women who have undergone for rheumatologic disease like lupus or for cancer, they get radiation chemotherapy. That those therapies can definitely damage the ovary and reduce the number of eggs available to get pregnant. In a similar fashion, that can also happen to sperm. Any history of any testicular damage, any history of undescended testes, also a history of radiation or chemotherapy can limit a man's ability to make viable sperm. Also of note, and this is especially alarming, a man's lifestyle, and especially if they're overweight, obese, can also severely hinder a man's ability to make viable sperm because excess weight, fat tissue makes a weak estrogen. The weak estrogen suppresses the hormones that help a man produce sperm. So the scary statistic that I learned not too recently, but is still in many on many news websites is that the average sperm count now is half of what it was 30 years ago. And one main reason is that men on average are heavier. They're drinking more. They just don't live good lifestyles, and that just makes it harder for them to produce happy little swimmers. So, when should you see a specialist? First, let's define what we consider infertility because these are where the hard stops should be. So, if you're less than 35, If you have not achieved a pregnancy after 12 months of consistent trying, you need to see a specialist. If you're older than 35, then we get even more aggressive, and you need to see someone after 6 months of consistent trying. That being said, if you want to come in a little bit earlier, then that's also very reasonable. If you come in at, say, the 10-month mark, that's also a very reasonable time to start a fertility evaluation, because remember, 80% of couples at the 6-month mark will have gotten pregnant with consistent trying. So what can one expect at the first visit? So first of all, a full history. Some of my patients get surprised when I ask them so many questions about all their medical issues and all their surgeries, but it all has an impact. Each patient is unique, and we want to understand the context behind their infertility. Because for things that might seem trivial, that might seem trivial to some people, those could be major red flags. Like one good example, if a couple comes to me and their partner states that, oh, they're relatively healthy, but they've been taking supplements in preparation for an Ironman event. Well, many supplements are laced with testosterone and can tank a man's sperm count. Um, if if a woman had a polyp removed and they did a very aggressive removal, well, she could have scar tissue in there. So we ask immense detail in all of our patients. Once we have that background, we know the patient to a T. Then we want to understand, are there any structural issues that could be contributing to this infertility? So we start off with an ultrasound. Another thing that the ultrasound helps us do is assess the relative size of the follicle pool. We do a follicle count. It's called an AFC, a natural follicle count. And it's one of the best ways to get a sense of how many eggs relatively a woman might have, or how big the egg pool is. Once we do that, we start off with blood work. And the blood work serves two main functions. One, we want to get a better sense of any endocrine issues contributing to the infertility, but we also do tests to make sure a woman is optimized for pregnancy. And following that visit, we set up everything to make sure the full evaluation can be done. So that includes doing additional testing to make sure we understand if there's any structural issue behind the infertility. A common test is an HSG. It's that X-ray tube test. And other tests include a semen analysis, because it takes two to tango. We need to make sure that there's enough sperm, just as there needs to be enough eggs. And for everyone who's listening, one very important point needs to be made. I find it, I'm going to be honest, I find it a little alarming when a lot of the onus is placed on women in situations of infertility. And I find many patients saying that, that the female partner wants to be tested first. I honestly push back against that, because it takes both partners to make a pregnancy and a healthy child. And I believe that all men need to be tested at the same time, because 30% of infertility is male factor. So really crucial that all of that's done. So once we go past that initial visit and all of that initial testing, patients generally meet back, usually within the span of 4 to 6 weeks, and general options to address the infertility is approached. So if we can find any clear endocrine, hormonal, or surgical issues, then first things first, that definitely should be addressed. Now, depending upon the severity of those issues and what those issues are, success can be variable. So that's why I'm not quoting an exact percentage. Say if there aren't any clear medical or surgical issues, one basic treatment that can be done is giving ovarian stimulation, usually with oral medications, and doing intrauterine insemination. And once that's done, the chance of pregnancy per month, per cycle, is about 20%. And most patients will say in the situation, that sounds pretty low. I would say not. Here's why. Because the chance of pregnancy for a healthy couple without any issues is about 20% per month. So this basic treatment, bullet number 2, gets you to the level of a couple with no infertility issues. So I'd say it's pretty effective. And I've had numerous couples get pregnant with this technique. Now, if IUI doesn't work, if intrauterine insemination doesn't work, especially after 3 to 6 cycles, then we need to get more aggressive, especially if the patient is older than 35, definitely older than 38. We need to go to in vitro fertilization. And the power behind that is in statistics. So each month, a woman releases 1 egg per month. With in vitro fertilization, we use the same hormones that a woman's body produces, but at way higher doses. So that instead of getting 1 to 2 eggs per month, we're getting 10 to 20 eggs. And it boils down to statistics. The more eggs we get, the more embryos we make. The more embryos we make, the more children you'll get. So that's Fertility 101 in a nutshell. I just want to thank all of you for your attention.